Hey, good evening. Thanks for joining. We're going to get started here in just a few minutes. We have a few poll questions up. If you would please answer those. They are anonymous. There will be a question and answer section at the end of the presentation as well, where you can ask Dr. McCullough questions directly. You'll do that by asking in the question and answer section. If you hover down at the bottom of your Zoom screen, you'll see a Q&A box down there. And you can send those directly to all hosts and panelists. Please don't send them to us individually or it may be missed. Again, just answer the poll questions and we'll get started here in just a minute. Good evening. Thank you for joining. If you've just hopped on, go ahead and answer the anonymous poll questions that you'll see on your screen. And we'll be ready to go just here in a minute. All right, good evening, everybody. My name is Kara, and I work for MEDTRONIC. Tonight, I have the pleasure of hosting this webinar where you'll get to hear from Dr. Casey McCullough. Dr. McCullough is a board-certified urologist and urologic surgeon practicing in advanced urology in Johns Creek. He began his medical journey at Colby College, where he graduated with a bachelor's in biochemistry with magna cum laude honors, and went on to complete his medical degree at Philadelphia College of Osteopathic Medicine. After this, Dr. McCullough finished his urological residency at the Albert Einstein Medical Center in Philadelphia, and finally his fellowship in laparoscopic and robotic surgery at the prestigious L'Institut, I'm going to try not to mess this up, Mutualiste Montessor in Paris, France. Dr. McCullough is an extensively published author in peer-reviewed journals and medical book chapters, a presenter at national meetings for urologists, and for multiple years he has been named top doctor. Dr. McCullough specializes in cancer of the prostate, kidney, bladder, urinary tract, stone disease, BPH, and the treatment of male and female voiding dysfunctions, which is what we'll be discussing tonight, along with the therapy that MEDTRONIC manufacturers called INTERSTIM. So without further ado, I'm going to pass the mic over to Dr. McCullough. You guys can hear more about overactive bladder and therapy called INTERSTIM that treats it. And just a few reminders before we get going. All of your phones were muted upon entry, or your lines. If you have any questions, feel free to type those into the question and answer box, the lower portion of your screen. All of your names will remain anonymous, and we'll answer those questions following the presentation. Likewise, please answer the anonymous poll question during the presentation. We may have another survey at the end as well. And without further ado, Dr. McCullough.
Great. Can everyone hear me okay?
Absolutely.
Okay. And can everyone see the screen? Second question.
Yes, sir.
So thanks for joining us today. I'm Casey McCullough with Advanced Urology. We have multiple offices all over Metro Atlanta to serve patients, and especially our patients who have overactive bladder and fecal incontinence. We're going to talk a little bit about that tonight. So overactive bladder is a very common problem with at least half of patients are actually even afraid to discuss it with their physician or provider for many reasons, some of which is they're just embarrassed by it. And it really controls their life in terms of going out, spending time with family and friends. They oftentimes have to map bathrooms and kind of figure out their plan of where their next bathroom break is. So tonight we're going to talk about understanding our overall bladder and bowel control, different treatment options that we have to control this situation, and then some advanced options once the simple options are no longer working. So OAB, or overactive bladder, is a very common problem. 1 out of 6 adults has this, which is about 37 million Americans. So just to put that into perspective, there are 12 million adults in the US with eye or vision problems, 17 million with asthma. So a huge population of patients that have this issue. Fecal incontinence, not quite as common, but still a big issue, about 20 million Americans. So the question is, you guys, my sound is breaking up. I'm not sure why.
Dr. McCullough?
Yeah.
Someone just said in the chat that the audio is pretty choppy.
Okay.
I don't know if you have the ability to change your audio source. Maybe we could do that before we get much further.
I just have it on my microphone, but I guess if you give me 30 seconds, I can see if I can get a headset, and it might be a different quality.
No problem. You may be able to just join audio from your computer directly as well.
That's what it is right now.
Oh, okay, got it. For whatever reason, now you sound okay, but a moment ago it was.
Should I keep going?
Yeah, now you sound fine. I'll pipe in if I hear you start to break up.
Okay. So, question is, what is normal and not normal? What is not normal is having frequent accidents, or having that urge where you have to run to the bathroom right away, or planning your activities around the bathroom, monitoring how much you eat or drink, or having to use pads or protective garments. So all these things are different strategies that patients use when they have issues with urination, and there's different things that we can obviously help this out. So how does blood control work? So it starts with a signal in the brain, actually in the pons, and the signal comes down from the brain, down the spinal cord, to the pelvic nerves, which then innervate or control the bladder. The bladder gets that signal, and you would sense that as a patient as, I have urgency, I need to go to the bathroom right now. And if anything is overactive or overstimulates that signal coming down from the brain, then we'll perceive that as worst urgency, or that frequency of having to go to the bathroom. Things that can increase that urgency are some medical conditions, like having a stroke, or a TIA, or a transient ischemic attack, or a mini stroke. Those can affect the brain, obviously, and can stimulate that signal coming down from the brain, causing bladder issues. Some medications can do it as well. Some other neurologic conditions like multiple sclerosis, or a traumatic spinal cord injury. Fecal incontinence is very similar in terms of the signal coming down from the brain down the spinal cord to the nerves in the pelvis, which control the rectum. And when the rectum is full, it stimulates its nerves that it needs to evacuate. And if that's overactive, then we can have fecal or incontinence from the back end. So obviously food and drink can cause it. What types of food and drink? So I always tell patients that anything that's acidic can make things worse in terms of your bladder health and hygiene. So coffee, tea, soda, anything that is acidic in terms of fruits, cranberries, lemons, tomatoes, things of that sort. Not that you can't eat those foods, but just if you're eating a lot of them and you notice your bladder symptoms or urgency are worse, then we need to make some changes that way. Different medications can also cause incontinence to worsen, namely diuretics like Lasix or Bumex, very, very common medications used to treat blood pressure. But the side effect of those pills is they cause urinary frequency, because the kidneys are in overdrive producing more urine. Now, obviously, if the kidneys are producing more urine, that urine will come down to the bladder, cause the bladder to become overactive if there's other issues with the bladder, and then you have that urgency. Reduced physical mobility. We see this oftentimes with patients that have had major surgery, namely orthopedic procedures. Let's say if they're not as physically mobile as they were before, very, very common to have incontinence afterwards. And then some more common medical issues: pregnancy, childbirth, any radiation to the pelvis for cancer, for other reasons, can affect the bladder and those pelvic nerves. Or if there's a pelvic floor injury traumatically, that can also lead to incontinence. There's different types of incontinence. One is stress incontinence, which is leaking urine when one coughs or sneezes, and that is from increased intra-abdominal pressure in the pelvis. And when that pressure occurs, the lower sphincter is not as strong as it maybe once was, and the urine can leak out without one's knowing it. Very stressful situation, but they call it stress incontinence. Urinary retention can happen when the bladder just doesn't empty very well at all, and patients hold on to extra urine. We've seen many patients recently where they may hold on to 1 or 2 liters of urine, might not even know it, but it usually happens over time slowly. And normal bladder capacity in adults is, let's say, 4 to 450 cc's of urine. So if someone's holding on to 1 or 2 liters, that's an enormous amount. And patients can have what's called overflow incontinence, where they're just full all the time, holding onto that urine until it gets to a certain pressure in the bladder, and then it just evacuates and the patient has little control over it. And lastly is overactive bladder, which is probably the most common, which is the frequency and urgency that we've been talking about so far. Stress incontinence, we already went over this. Much more common in women. Men can have this as well if they've had prior pelvic surgery, let's say prostatectomy, because that can alter the anatomy in the lower pelvis and have higher incidence of stress incontinence. Tension, again, bladder is full, can't empty, patients can overflow where the urine just kind of leaks out, where they don't have any control or awareness before this can happen. And OAB. Fecal incontinence, not as common as urgent incontinence, but still a huge problem in the United States. And this is that urgency to go right away on the back end where you can't hold your bowel movement and can't get to the bathroom in time. Sometimes it can leak out passively, which is called passive incontinence. So the good news is we have a lot of great options and treatments for patients that have these types of issues. The first plan is obviously diagnose the problem. And we always ask patients about their urinary habits when they see us in the office. But if you're seeing a family doctor or family provider, don't be afraid to bring that up with them, because that can start the conversation in terms of what may be right or wrong in terms of your bladder health. Lifestyle, dietary changes are the first treatment option that we always talk about. If that fails, then medications would be option number 2. And then number 3 would be our advanced therapies. In terms of lifestyle and dietary changes, like I mentioned before, cutting down on acidic beverages can help. Exercise in terms of weight loss can help as well. There's less pressure on the bladder, which can decrease some of the impulses that the bladder would receive in terms of making one feel they have to use the bathroom. Sometimes we send patients to physical therapy, to pelvic floor physical therapy specialists, which deal just with the pelvic floor and pelvic floor dysfunction in terms of patients that have incontinence, and that can often help, especially those patients who have stress incontinence. Medications are treatment option number 2. And initially, these medications were very nonspecific and affected not just the bladder, but other areas in the body, namely the digestive system. So these medications are very common in most of our patients have usually tried them by the time they come in to see us. Some of these medications are oxybutynin, Ditropan, Vesicare, Nablex. The problem with these medications is that they affect, like I said, the GI tract. So they cause a lot of dry mouth, constipation are the 2 biggest problems that we see with them. And it causes so much of an issue that most patients stop these pills within a few months of starting them because the side effects are so intolerable. It can also increase the blood pressure a bit and sometimes cause blurry vision or even confusion. So they're not great medications to stay on for the long term. Will they cut down on the urgency and frequency? Yes, but the downside is the side effects are the real problem. Once patients have...
Dr. McCullough.
Yes.
Sorry to interrupt you. Do you mind switching to audio on your phone? It just intermittently it's clear, and then out of nowhere it gets really choppy.
Okay, how do I do that?
I can walk you through how to do that if you need me to.
So I'm going to go to my phone.
have to click the little up arrow above the phone receiver in the bottom left-hand corner of your Zoom screen. And it.
Should I go back to the email?
No, if you just hover over the Zoom screen. Sorry, everybody that's on. Thank you for dealing with this. So just on the bottom left-hand side of the Zoom screen, if you sort of scroll towards the end of the screen, you see where you can mute yourself at the bottom left.
Let's see. I have to get out of the presentation here.
If you should be able to just hover your icon or your mouse over the outside of your screen. I'm trying to see what you're looking at the same time.
There's a little bar at the bottom. It's got a red.
You may have to exit presenter mode. Sorry, everybody who's on. Just trying to get you a better connection so you can actually understand what Dr. McCullough is saying. Go ahead and exit presenter mode. There you go. And then if you hover over the Zoom window, maybe above the.
Yeah, okay. Mute.
If you click the little arrow above the mute button, a box should pop up, and then you'll choose the far right option that says call me. You'll just type in your phone number, it'll call you and connect.
It doesn't have that. Switch to phone audio.
Yeah. Mm-hmm.
Call me. Can you hear me now? Hello?
Much better. Very clear.
Okay. So I'm going to go back to resume session.
Perfect. Thank you all. Sorry about that. I just wanted to make sure we could hear you okay. Thanks, Dr. McCullough.
Okay. Is that better?
Much better. Take it away.
Okay. So advanced therapies. This is where we're going to start once patients have failed dietary measures and medications. And the main therapy that we use is a MEDTRONIC INTERSTIM system. Second option would be injected medications, and these are for bladder control. In terms of bowel control, the MEDTRONIC INTERSTIM system would also treat that as well, because it's the same pelvic nerves that control both, which is a nice, anatomic advantage, and other surgical options for bowel control, which we're not going to really get into tonight. Screens here. So Botox we use in the bladder only is another option for patients that have failed medications and simpler measures. Botox is the same Botox that we use on our face for plastic surgery indications in terms of reducing wrinkles. We're not putting it in the bladder to reduce wrinkles, obviously, but it paralyzes muscle tissue. So the bladder itself is a muscle, the detrusor muscle, and it's going to work to paralyze the detrusor muscle. And when that happens, that urgency and urgent continence, those symptoms of having to go right away, will be much improved. The issue with Botox is that it is a temporary fix, and typically lasts for 3 to 4 months. I've seen patients get 6 months out of it, maybe. But after that, the Botox, just like when you inject your face, it wears off. You need more Botox. So what that would lead to was multiple procedures every 3 to 6 months, over and over again, to keep putting the Botox back into the bladder. The other risk of Botox is that it can sometimes work too well. And if it works too well and your bladder can't squeeze at all, you go from having overactive bladder to underactive bladder and can't empty at all, and may need a catheter for sometimes several months while that Botox wears off until your bladder can work again. So it does work on certain patient populations. It is an option, but there are some side effects associated with it. Sacral neuromodulation, the MEDTRONIC INTERSTIM system is option number 1 that we use. This is a simpler system, which is not going to have the side effects of urinary retention.
And this lasts for a longer period of time. You're not going to need repeated procedures every 3 to 6 months. So the way that this works is we do a trial run first to see whether it works or not. What we do is place 2 little thin strings or wires, which are thinner than a string, in the lower back. There's no cutting, no incisions. It's done through a small little acupuncture needle. In the lower back, we numb things up. We place that needle into the correct space, and then the string goes through the needle, and the string stays, and the needle comes out right away. The little string is attached to a small flat battery box, which we tape to the patient's lower back, and they wear it for 2 or 3 days. That battery box sends a small signal down each one of those strings to where the string is laying next to the nerves that control the bladder, and basically gives the bladder more control. So this either works or doesn't work. It has a very high success rate, 80 to 90% in our patient population. So if it works, which is fantastic, the patients will notice a benefit almost right away. Within that 2 or 3 day period, they'll go from wet to dry almost overnight. So it's pretty amazing how it works. It's not going to cause any of the bad side effects in terms of dry mouth or constipation that the medications previously had caused for us. So if this works and the MEDTRONIC INTERSTIM or sacral nerve stimulator is effective, obviously the patient is not going to walk around for the rest of their life wearing this battery box taped to their lower back. That will get replaced at a separate setting. We place a small little battery, and that's on the screen here. You can see there's 2 little batteries there. And those batteries are implanted just underneath the skin, and they can last from 10 to 15 years, so which is fantastic. And they will always provide that stimulation to the pelvic nerves, give the patients control in terms of their frequency and urgency, and also those patients who have fecal incontinence. So this tends to be a better option for patients. It is a minor procedure, which we do in an outpatient setting. Patients obviously go home the same day. It takes about an hour or so to put the little battery in and place it correctly, and then patients are off and ready to go. The battery itself is MRI safe and MRI compatible, which is fantastic. So a lot of our patients, especially our MS or multiple sclerosis patients who have neurologic issues, or have patients who have back problems who need frequent MRIs for other reasons, we can safely do that with this newer technology. We basically put the INTERSTIM device in MRI mode, very easy to do, and then they can have their imaging studies done. Safe and effective, 90% success rate for those patients who have fecal incontinence, about 76%, 80%, 90%, which we see in our office in terms of patients with overactive bladder issues compared to standard therapy. So a great improvement in quality of life with a simple outpatient procedure that we do the test run first to make sure that it is going to work. So question, is this going to be right for you or not? First, we have to obviously diagnose the issue in terms of incontinence. Is it the right type of incontinence? We often have patients submit some voiding diaries, which are a piece of paper with a graph or some ledgers lines on there. We mark down for 2 or 3 days of all the times that a patient's going to the bathroom, how often they're going, the times, and how strong the urge or incontinence is, or having any accidents. So we get a snapshot of how severe the leakage is beforehand. And then during that 2 or 3 day test, when we do the test run, the patients will fill out another voiding diary just to compare the before and after. And that's what obviously the insurance company is going to want to see. Is this really effective or not? Patients are going to know because they're living with it for sure, but we need to see on paper documented of their improvement. So we see a lot of great patients that have failed multiple therapies in the past, suffer for years from incontinence and leakage, and really have changed their lives around in terms of better control, being dry, being more active in their life and lifestyle and things that they want to get done. That's the bulk of the slides here. I'm happy to take questions for anyone that has specific questions about the presentation or overactive bladder at this time.
So far, Dr. McCullough, we have just one question. Just a reminder to the rest of the attendees, if you'd like to ask the question, Dr. McCullough, just type it into the question and answer box, not the chat function. And if you, we'll give you a few minutes to type some questions there if you have any. First question is this covered by insurance?
Yes, it is covered by insurance, covered by Medicare and the government payers and almost all private payers. The caveat, of course, is we don't just jump to this. We have to make a timeline and a strategy of seeing where things are. We try to simple things first in terms of the dietary changes, lifestyle changes, medications, and then you document success or failure along the way. And once we've gotten to the medication route and things have not worked, we have almost never had a failure in terms of insurance coverage for the MEDTRONIC device.
Another question. Someone asked, will it cause any issues if you suffer from lower back pain from disc issues?
No, this battery is placed much lower down in the pelvis. It's really the third sacral nerve, which we're targeting in terms of bowel and bladder control, which is much lower in the pelvis than most patients who have back problems at L5 and S1. So we have patients that have had pain stimulators, different lower back surgery with hardware in their lumbar and upper sacral spine, and have not had any issues with this. So great question, but we can easily avoid placement with patients that have had prior surgery in their back from either orthopedic or other neurologic surgeries.
Absolutely. Someone else asked if they can have a copy of this presentation. It will be uploaded to the Advanced Urology website, so you can find it there, and you will also be emailed after this. And there's an automatic survey that will launch at the end of the presentation, and you can request more information there as well. Next question is, do I need 2 separate procedures to treat overactive bladder and fecal incontinence if I have both?
No, the only 2 procedures, one is, assuming, again, we failed lifestyle changes, simple dietary measures, medications, and we get to third-line therapies, which is this sacral nerve stimulator. If a patient has both urge incontinence, OA, or overactive bladder and fecal incontinence, the test, the 2-day test that we talked about would treat both. And then if there is success and there is benefit, then the sacral nerve stimulator would treat both the overactive bladder and the fecal incontinence, because it's the same third pelvic nerve which we're targeting. So it would treat both. You do not need a second procedure. You do not need 2 neurostimulators. Just one that would treat both conditions. But you would need 2 separate procedures. One is the test run to see whether it works or not. And I think most patients would want that before anything is implanted internally. So it's an external test to see if it works. If it works, then we go ahead and put the stimulator in as step 2. Hope that answers that question.
Just a reminder to attendees to type the questions in the question and answer box and not in the chat feature. I will read them, but they should go in the question and answer box. Anyhow, next question is, how safe is the implanted battery over time?
Battery is super safe. I mean, I've been doing this for 15 years and have never had an issue with a battery that's, let's say, leaked or had an issue like that. Sometimes if a patient has, let's say, had a car accident or some traumatic event, after the battery's been placed, it can maybe be dislodged where the lead is not in the position that it was before. And if that happens, it's not an issue. We would just take out the battery and lead and put it back where it's supposed to be. So that's the only thing that we typically see.
Next question is, are there any concerns for patients who might be considered high risk for prostate cancer?
Not at all. We've had patients that have had, prostate cancer, bladder cancer, any, other pelvic malignancy, and had overactive bladder issues, and we treat them the same. Their bladder needs to be treated. There's no reason why they should have to suffer with incontinence. So we would go ahead and treat them accordingly.
Someone asked, how quickly can I get an appointment with you? At the survey, and if you all didn't see in the initial poll, Advanced Urology has been really gracious and allowed us to open up some time before the new year when insurance renews, so that you can get in with Dr. McCullough before the end of the year. In the survey, those times that are available will also be shown to you at the end of the presentation. Dr. McCullough, if you have anything to add to how quickly someone could get in to see you.
Usually pretty quickly. Oftentimes we do have same-day appointments depending on the office and provider that's available, especially for urgent issues. Let's say someone's obviously in severe pain with a stone or something that needs to be treated immediately. They would be brought in. In terms of overactive bladder, that's still obviously an important issue, and we would get patients in very promptly to be treated.
Great. Next question, a little bit involved. So this patient had a mesh sling over a decade ago. It helped for a while, but then they did urodynamics 2 years ago and showed overactive bladder and fecal incontinence. The medications they were prescribed caused cardiac issues, so they couldn't continue taking them. They did pelvic floor therapy unsuccessfully for months, and they're scheduled with another urodynamics tomorrow to move forward with this device for the OAB. Their question is for fecal incontinence. Is there anything else to help improve, possibly remote Kegel balls or anything?
There are some different things. There is actually Kegel exercises are more for urinary incontinence, but it's the same pelvic floor muscles that one would be contracting to kind of tighten up the anal sphincter as well. There's actually a newer device. It's called an EMSELLA chair, EMSELLA. And we actually have a few of those devices, and it actually puts your pelvis in overdrive in terms of it makes your pelvis do some ridiculous amount. It's, I think, 10,000 or 12,000 Kegel exercises in one setting. And it's about a 20, 30-minute session where you go and sit on this chair, and it's a high vibration chair. It's a magnetic chair, and it will help strengthen those muscles much quicker than you could physically do on your own doing exercises. So there are some other non-invasive things that you can do that can help fecal incontinence back end. Colorectal surgeons can do surgeries back there to try to bulk things up. On the back end, it's obviously a very painful surgery, and recovery is not quick. But there are other options for fecal incontinence. But certainly the neurostimulator is the simplest, and certainly with the least amount of side effects.
Okay. And that person also said that they have urgency. So I'll just clarify that the INTERSTIM device and the test would treat overactive bladder, including urgency and frequency. So if you have urgency, the INTERSTIM would be appropriate to treat that as well. Someone else asked if the first step is to do the test.
Correct. After we've failed the preliminary workup, we would do the trial run first to see if it works. And that is the simplest thing to do, because it's simpler than even looking in the bladder with a camera, because there's nothing internal. There's no cutting. There's no incision. There's nothing. It's basically an acupuncture needle that we use to numb up the lower back. And then we put the little lead in the correct position, and then we just tape everything there. During that 2-day test, because it's taped on the outside, we just can't get it wet. So we ask patients not to shower, go swimming, tub bath, things like that. A sponge bath is fine to clean on the armpits and things of that sort for those 2 days, but minor inconvenience, just can't get it wet. But it's worth that minor inconvenience to see whether this is going to really help things in terms of your bladder control.
Like test driving a car. All right. That is it for questions. Kind of linger for another minute and make sure nothing else comes in. Thank you so much, Dr. McCullough, for your time and for talking about overactive bladder and INTERSTIM therapy.
My pleasure. I think, we're fortunate enough to have enough offices and staff in greater metro Atlanta throughout, multiple cities. If you go to our website, advancedurology.com, offer same-day appointments to get patients in for whatever their issue is, whether it's urinary issues or stones or blood in the urine, urologic malignancies. But we really do our best to kind of serve patients as quickly and as compassionately as possible. So always a pleasure to take care of patients and really improve their quality of life.
Absolutely. Someone else asked if you could clarify what that Kegel chair was called.
EMSELLA, EMSELLA.
And then one more question. Someone asked, what if they're not comfortable, must be a female, seeing a male provider?
Not an issue. We have two urogynecologists in our practice, which are female, as well as multiple physician assistants who are female. And they are under our, the physician assistants are under the, I have a overseeing provider or physician on top of them. So we have patients that prefer a female provider, and we can certainly accommodate those requests very easily.
Yes, Dr. McCullough has a lovely female physician's assistant named Mary Kate, and if you're not comfortable talking with Dr. McCullough, she can certainly help.
For sure.
All right. Well, I think that's it. Unless anybody else has any other questions, we will wrap it up. Again, there's going to be a survey that's launched after I close the webinar out here, and that will give you the ability to choose an appointment time, and you can also choose to be contacted by the office if you wish. So thank you everyone for attending. Thank you so much, Dr. McCullough, for your time, and look forward to getting you all into advanced urology.
Thanks so much, everybody. Have a good night. Thank you.
So it's not working either time. And for no, you just have to sign up for forms. It's kind of the hospital, you have people who choose to leave their own election.